So hi guys, it's Rod Quilitz from Moffitt Cancer Center. I think most of you have met me. I'm clinical pharmacy coordinator for infectious disease and antimicrobial stewardship at Moffitt, just across the street. Here to talk about invasive fungal infections. I did, in fact, recently. This is actually a two-part lecture. One is more bug-related, one's more drug-related. The last time I was in this room, I asked bugs or drugs, and I think because we had a bunch of pharmacy students in here, we got drugs. So this time I'm going to talk about some of the organisms that we have to combat. But yes, I'm a pharmacist, so there'll still be drug stuff. So what I'm going to try to do today is talk about some of the major risk factors that predispose immunocompromised patients to invasive fungal infections, and particularly I'm going to lean towards my patient population, the oncology patient population. Briefly review the most commonly encountered fungal pathogens in clinical practice, compare and contrast the available antifungal agents. That's kind of more the part two of the lecture. So, of course, fungi have been in existence for over 300 million years, and there are over 2 million species. They're free-living organisms. Most of them are of limited pathogenicity. Less than 200 species out of the 2 million are associated with human disease. Positive attributes, you have edible fungi like mushrooms, right? You have yeasts that are responsible for baking and for brewing of beer, for example, right? No penicillin without penicillium, so we can thank the fungi for that. But as we headed towards the end of the 20th century, and now we're into the 21st century, now we're starting to encounter some newer rare mycoses. We're starting to see more resistant fungal species, and a lot of it has to do with the fact that we are supporting patients through more and more levels of immunosuppression and giving more immunosuppressive therapies to, say, cancer patients, for example, and keeping those patients alive to get these infections. Obviously, you need to get invasive fungal infection, you need to be exposed to the fungi. You need to acquire the potential pathogen, which will compete with your microbiological flora. If you have a disruption of the skin and mucosal membrane, that makes it much easier for the fungus to become invasive. And you have to have sufficient growth of the organism to overcome host defenses. So, there are a number of immunodeficiency states, of course, either drug-induced. So we have a cytotoxic chemotherapy, for example, radiation, particularly whole-body radiation, corticosteroids, immunosuppressive agents to prevent graft-versus-host disease or graft rejection, depending on what you're talking about. Patients with congenital immunodeficiency states like CGD or SCIDS or MPD, acquired like HIV/AIDS, for example, and the extremely young and extremely elderly are also at increased risk due to impaired immune systems. Now, in terms of general statements, some of the risk factors for invasive fungal infections in general are going to be predominantly having to do with neutropenia and lymphopenia. So, and there's some variance between the fungal species, and we'll touch on that lately as to which are most important in any given patient, perhaps. But the longer and more severe the neutropenia, the greater the risk. And we'll see this with Aspergillus, for example, where the risk starts to really shoot up after 14 days of neutropenia, particularly profound neutropenia, which is defined as an ANC of less than 100. Also, though, patients who have impaired lymphocyte activity, as monitored by the CD4 cell count, those who have the lower the CD4 count, the greater the risk for some of these infections. And Aspergillus is a good example where both can be risk factors. Okay, so this is a little diagram here, just basically showing fungal cell structure, a little cartoon, right? So we have the cell membrane, which is where the polyenes have their activity. So guys, name 2 polyene antifungal drugs. What's that? Amphotericin B, right? That's the classic, right? Name a second polyene antifungal drug. Okay, nystatin. We use it, we use it topically because it's even more nephrotoxic than amphotericin B, if administered intravenously. But it is indeed in that class. Then we have the agents that have impact on cell wall synthesis, which are echinocandins. so caspofungin, mycofungin, and igilofungin. We have the agents that impair ergosterol synthesis, which will be our azole antifungals, fluconazole, itraconazole, voriconazole, posaconazole, isavuconazonium, etc. And we have one agent which actually acts the site of nucleic acid synthesis by inhibiting nucleic acid synthesis. This is the pyrimidine analog. Does anybody know which one this is? Flucytosine, thank you. Okay, so this is, of course, a visual representation of a typical yeast and a typical mold, right? The yeasts are unicellular. They're round or oval in shape, and they form fuzzy matted growth called mycelia, and they reproduce by budding. The molds, on the other hand, consist of thread-like filaments, or hyphae, which can be divided by transverse walls, which septated hyphae, or without divisions, which would be aseptated hyphae. And then we have the Candida, non-motile spores, which are responsible for asexual reproduction. And just a couple concepts to show real quick, right? So this is, when we say a septated hyphae, this is what we mean. So you can see how there's like little walls that subdivide this. Anybody want to guess what this septated mold is? 45 degree? It's Aspergillus, yes. Okay. This is a classic example of aseptated hyphae, right? And you can see how there's no barriers, there's no subdivisions here. Also, this is like the classical moose antler appearance of mucor, yes. And another common term we see is pseudohyphae. And so what we're looking at here is, of course, Candida, but it's almost like a string of pearls, right? And it can be, it can look to the untrained eye as if it's a filamentous element, when actually it's just a collection of yeast cells in a filamentous shape, right? So you'll see that. So when we see this in hyphae, we're thinking mold. We see the term pseudohyphae. Of course, we're thinking yeast. So there are more fungal pathogens that I'm going to have time to talk about today, and I want to, hit some interesting information. So I'm going to predominantly talk about Candida, Cryptococcus, Aspergillus, Fusarium, and the zygomycoses or mucormycoses. I'll touch base a little bit on susceptibility of some of the other organisms as well, though. So starting off with Candida, right? So starting off with the yeast. Candida is part of the normal flora of the skin, the female genital tract, and the GI tract. Neutrophils are critical component of the defense against Candida becoming an invasive pathogen. We can have mucocutaneous infections, oral pharyngeal, esophageal, vaginal, or systemic. Your Candidemia, disseminated candidiasis, or candiuria, although candiuria is often not clinically significant. So disseminated Candida infections are clinically important, right? In some series, in one series, fungemia, which was predominantly candidemia, accounted for 19% of positive bloodstream infections in severely septic ICU patients. And this was a general internal medicine hospital, not Moffitt Cancer Center, right? There are a number of risk factors that we have to consider, right? Neutropenia, hematological malignancy, diabetes, high-dose corticosteroids, immunosuppressive therapy, angioplastic therapy, central venous catheters, hemodialysis, TPN, multiple prolonged antibiotics, extensive gastrointestinal tract surgery. And Candida can be difficult to diagnose, right? So in the neutropenic patient population, there have been series of patients who expired, who were found on autopsy to have candidemia, disseminated candidiasis, but actually had negative blood cultures pre-mortem for Candida. Now, the technology is improving, so this is actually getting better. The disseminated candidiasis can really go almost anywhere it wants, right? So we find Candida as a component of an abscess. We find it as a component of Candida peritonitis. You can see Candida osteomyelitis. It's rare, but you can have hematologists spread to spine, sternum, or femur, for example. Patients, you certainly see Candida central venous catheter infections. You can see fungal endocarditis, and superinfection of bacterial endocarditis has been reported. CNS Candida is rare, but you can see it predominantly after neurosurgery. In terms of like a septic arthritis, we've seen it, right? Mostly stress post-trauma or patients with underlying joint disease or prostheses. This tends to be a monoarthritis, so you wouldn't expect this to happen in like both knees, for example. That would tend to be more likely to be autoimmune. Now, in terms of the lung, so typically when we see Candida species from a respiratory culture, bronchoscopy, sputum, right, we will disregard it, right? We will consider it to be upper respiratory colonization, and I absolutely agree with that. However, there is a less common phenomenon that you'll run into with a disseminated candidiasis where you have hematogenous spread to the lungs. And I'll show you a photo of what that looks like. That's very much like a septic emboli kind of picture. And from the urinary tract, so again, most of the patients who have yeast in the urine, it's usually not clinically relevant, but it can be if these patients have infected stents, for example, or they have they can have infected catheters. They can also have a fungus ball, which obviously is concerning. So here's some sites of disseminated candidiasis, right? And so this is your classic Swiss cheese appearance of the liver, right? So this is what we used to call hepatic splenic candidiasis for a couple of common sites where Candida likes to disseminate. But what we're looking at here, you see the arrows, these essentially holes in the liver. Does anybody know what we're looking at here? Like why we have holes in the liver in this patient with disseminated candidiasis?
The white blood cells attacking the yeast itself.
Yes, exactly. Exactly. So you have all these. So you have a severe immune response of the neutrophils to the disseminated Candida. So you will not see this in a neutropenic patient. You can see this in a patient shortly after neutrophil recovery, though, as well as like all of a sudden their alkaline phosphatase starts shooting up. Now here to the top right, you see these multiple, very circular lesions. That's disseminated candidiasis to the lungs. That's a nodular pneumonia caused by Candida, really only in the setting of disseminated candidiasis. Usually there are other organs that are showing involvement as well. And I put this here certainly not to make sure we didn't forget to mention that patients can have ophthalmic involvement as well, and this is less common in the neutropenic patient population, those who rapidly clear their cultures, but ophthalmology follow-ups afterwards are recommended. Okay, so in my group, candidiasis, candidemia is in high-risk patient populations like solid organ transplant or hematopoietic stem cell transplant. The incidence is relatively low because of the efficacy of the prophylactic antifungals that we've used. But the concern being that in a high-risk patient population, there can be up to a 1 in 4 attributable mortality associated with invasive candidiasis. Okay, so it's very important too that we're familiar with the spectrum of the antifungal agents. And here for Candida, I tried to break them up into groups that had some kind of relationship to each other, right? So I do want to mention that even though the micro lab will usually tell you quickly, yeast, Candida albicans or not Candida albicans, right? Obviously, there's a lot more to the story, and if this is a site that you're concerned about this being a pathogen, it really becomes important to get at least the speciation, and in some cases susceptibilities as well. Like our lab will do it automatically for blood, but any other site you're going to have to request it. So your Candida albicans, your Candida kaffir, dublinensis, tropicalis, they are usually susceptible to all of our available appropriate agents, right? Fluconazole, ITRA, Voriconazole, POSAISV, Avconazole, kind of candins, amphotericin B. Candida parapsilosis, Candida garramundae, very similar, although they tend to have a little bit higher MICs against the echinocandins. So once in a while you'll see a echinocandin breakthrough of parapsilosis or garramundae. Candida lusitaniae is a lot like albicans. It's a lot like a Candida albicans that happens to be amphotericin B resistant intrinsically.
I have a patient right now with BMT who was on prophylactic mycofungin, and he ended up having Candida parapsilosis in his blood. So yeah, we did see that breakthrough there. But it's everything we tested, every other thing we tested against, it's susceptible. So we're using fluconazole to treat it now.
Yeah, absolutely, and typically that's going to be the treatment of choice for parapsilosis garramundae will be fluconazole, absolutely. Now, when you get to Candida glabrata, now you're talking about an organism where fluconazole, itraconazole, also sometimes the extended spectrum azoles like voriconazole, posaconazole, isavuconazonium may have issues, right? You can see sensitive, dose-dependent, or resistance. And the first-line agents tend to be the kind of candins and amphotericin B, and we're able to fluconazole, for example, we can get a sensitive dose dependent. We may be able to rev up the dose and overcome this mechanism of resistance. Does anybody know what the Candida glabrata mechanism of resistance is? Okay. Well, this originally a oncology pharmacist, this kind of thing's near and dear to my heart, right? So the efflux pumps, which also is relevant for some chemo resistance too, but yeah. So Candida glabrata likes to produce efflux pumps that can be variably effective at pumping out the azole antifungals, and so for Candida glabrata, you really want to have your susceptibility data before you consider using fluconazole or other azoles to treat this agent. It is worth mentioning that we are starting to see more and more reports of echinocandin resistant Candida glabrata. We've seen a couple that are at least in vitro intermediate. So watch out for that. That is a concern, possibly a consequence of overutilization of echinocandins. So antifungal stewardship is a thing. Candida krusei. So fluconazole is intrinsically not active against Candida krusei, although voriconazole usually maintains its activity, and this is more of a enzyme interaction, right? So fluconazole is sterically unable to interact with the target enzyme in Candida krusei. So it's alteration of the enzyme itself, and kind of candins and amphotericin B tend to be your first line agents here, but sometimes often voriconazole is an option as well. I wanted to mention Candida auris. I thankfully haven't encountered this one yet myself, but it's something that we need to be aware of, right? So the CDC sent out a clinical alert on June of last year, 2016. There's this emerging multi-drug resistant yeast causing invasive hospital-acquired infections, predominantly fungemia, associated with high mortality. Initially reported in South Korea, India, South Africa, Kuwait, Colombia, Venezuela, Pakistan, and the UK. In those series, and this report, they mentioned that they're almost always fluconazole resistant. More than half of them were fluconazole resistant. 1 in 3 were resistant to amphotericin B, and a few were resistant to echinocandins, and there actually were some isolates that were resistant to azoles, polyenes, and echinocandins, meaning that we literally have no agent that is optimal for this Candida species. There was an update in November 4th of last year, and they mentioned there were 13 cases in the U.S. and they had data on 7 of them. And they mentioned that 4 out of these 7 expired from their invasive candidiasis, and they were 5 out of 7 were resistant to fluconazole. In this series, 1 out of 7 was resistant to amphotericin B, and 1 out of 7 was resistant to the echinocandins. So this is certainly a species that that we want to be on the alert for, and also, you know, let the Department of Health know if it pops up in our neck of the woods. Okay, let's move from Candida to Cryptococcus. Staying with the yeast for now. Cryptococcus is a ubiquitous encapsulated yeast. It's common in the soil and found in pigeon droppings, and it's acquired via inhalation. Most common sites of infection, lungs, so cough, rales, shortness of breath, the most common symptoms. Central nervous system, non-specific meningeal symptoms, headache, fever, nausea and vomiting, altered mental status. You can have associated cryptococcemia as well, which I just like the sound of that word. Historically, it's been Cryptococcus neoformans that we've been worried about. Non-contagious systemic infection, profoundly immunocompromised patients, big one in HIV/AIDS. We also see Cryptococcus tends to be one that's more common in the lymphocyte impaired patients, right? So you see it in HIV/AIDS. You can see it in allogeneic stem cell transplant patients more commonly than you do in AML patients with prolonged neutropenia. And we now have to be aware there's also some non-neoformant species out there, most commonly Cryptococcus gattii. These infections began in relatively immunocompetent patients in the Pacific Northwest, but they have spread throughout the country. There is some data suggesting that there may tend to be a little bit less susceptible to fluconazole. That data is not really confirmed at this point, I don't think. So if you have non-meningeal cryptococcosis, you may be able to treat the patient with fluconazole for 6 to 12 months. But if your patient is immunocompromised, or they have severe pulmonary cryptococcosis, or they have a cryptococcemia, then you're going to treat them as you would a patient with CNS disease. And the idea is, and here I'm clearly just stealing from Infectious Disease Society of America, their guidelines. They have some excellent antifungal guidelines. For candidiasis, for cryptococcus, and they break down recommendations for HIV patients and transplant patients and non-transplant patients. The basic concept tends to be the same, right? The treatment of choice is induction therapy with amphotericin B plus flucytosine, because you get more rapid clearing of the CSF with the combination. Or you can use a lipid formulation of amphotericin B, still ideally with flucytosine. So usually you're talking about 2 weeks of induction therapy. However, if your patient cannot tolerate flucytosine, now you're stuck with more like 4 to 6 weeks of the amphotericin B. And then when you drop down to consolidation and maintenance therapy, you're talking about varying doses of fluconazole. Usually you're going to be treating these patients for greater than or equal to a year of duration, and you're going to want secondary prophylaxis if the immunocompromised state, which put your patient at risk for cryptococcus in the first place, persists. And again, similar recommendations for transplant patients, similar recommendations for non-HIV and non-transplant patients. Okay, so we'll move over from the yeast, we'll talk about Aspergillus. Right, so Aspergillus is a ubiquitous mold. It's found in soil, water, and plants. Some of the more common species that we encounter: Fumigatus, Flavus, Niger, Pterius, and Ustis. There are superficial infections. So we had a patient who was neutropenic, fell, scraped their knee on the sidewalk, got Aspergillus into their, had a cutaneous involvement of Aspergillus. Once we treated it and the skin healed up, the patient was at no further risk. It is an allergen, right? So a lot of patients who are heavy marijuana smokers, for example, can have allergic reactions to Aspergillus. Aspergilloma is obviously what we're really concerned about. Aspergilloma, fungus balls in the lungs, sinuses, CNS predominantly, invasive disseminated infections. This is a very old graph, but I've kept it because it shows the relationship between invasive pulmonary aspergillosis and the duration of neutropenia. So you can see how once you get past about 2 weeks of neutropenia, the risk really skyrockets for invasive pulmonary aspergillosis. Obviously, this was without prophylaxis. Okay, so diagnosis of invasive aspergillus remains a challenge. So usually the only cultures that are going to turn positive for aspergillus, you'll occasionally get a positive respiratory culture, sputum or bronchoscopy. Just because it shows up in the sputum or bronch doesn't mean that the patient has invasive pulmonary aspergillosis, right? I mean, there is such a thing as being colonized, and we see that a lot in like lung cancer patients, for example. So is your patient at risk? Do they have other signs and symptoms and evidence? We can examine the invaded tissue. Historically, even with a biopsy or bronchoscopy, we only get a positive identification in about 40% of the cases. This is improving, arguably, to closer to 50 to 60% now that we have some additional testing modalities. One of them is a galactomannan assay. Right? Galactomannan is a cell wall polysaccharide, which gives an opportunity for early diagnosis. Early on, there were concerns about false positive galactomannan assays in patients who were receiving Zosyn, piperacillin tazobactam IV, because it's derived from penicillium. Penicillium also has a galactomannan, but the newer formulations that we have now do not have this concern, so that we should probably take that out of my presentation. It has decreased sensitivity in patients who are already on anti-mold agents, so as a screening tool, it's not as useful in patients who are already on voriconazole or echinocandins, in our experience. Initially, it was approved for a serum test only, and now you can get serum and BAL galactomannan assays, and that's probably like if you have a patient with suspected pulmonary aspergillosis, you should probably get a serum galactomannan and ask them to get a BAL galactomannan, because each one improves your chances of getting your diagnosis. Now, the serum, you can also have, particularly with the serum, you can have false positives. It's actually recommended to get a repeat serum galactomannan assay, especially in the setting of screening high-risk patients for aspergillus, because of the number of false positives. But often we're going to wind up making tentative diagnoses based on CT scan results, right? So here's what aspergillus can look like on the CAT scan. So, you can see these very prominent nodules here, which would be what we call a positive pharmacist sign, right? Because you don't have to be highly trained in reading CTs to know that's not right. You see that little fuzziness around the nodules. I could actually call that a pharmacy student sign on that one. And that fuzziness, of course, is the halo sign, right? The ground glass attenuation that surrounds the nodules due to alveolar hemorrhage, right? Because this is an angioinvasive organism. And this is an early sign of aspergillus, and that halo sign will go away over time. Also, we have the air crescent sign, which this is, they don't always look this pretty, but this is a necrotic area within the nodule. This is a later sign, and it's not seen during neutropenia for exactly the same reason that we discussed when we were talking about hepatic disseminated candidiasis. It's the same concept here. Okay. Obviously, this is an example of where CNS went to the brain, right? So, if you go to the sinuses, you can go to the lungs, go to the sinuses, and go to the brain. And, so you see these large black necrotic areas, lots of hemorrhage as well. This is an example of like a superficial cutaneous aspergillosis infection where there was a trauma. And we care about aspergillosis because aspergillosis is associated with a high mortality rate. And the greater the degree of immunoinsufficiency, the greater the risk for mortality with aspergillus. So a lot of times with these invasive fungal infections, in some of our prolonged neutropenic leukemic patients, it feels like what we're trying to do is keep the patient alive until they get their neutrophils back and finish fighting off the infection themselves. Sometimes we can clear the infection, at least temporarily, just with antifungal drugs, but, it's certainly no guarantees there. Obviously, fluconazole does not have activity against aspergillus. Itraconazole has some activity, but would be considered a third-line agent. Voriconazole and isavuconazonium are considered first-line agents for voriconazole. Posaconazole, generally a second-line agent. Echinocandin, third-line agent. And amphotericin B, generally considered a second-line agent predominantly because of the greater toxicity. Also because we have some data showing that voriconazole is superior to conventional amphotericin B. We'll touch base on that data. Aspergillus terreus was in the past was the biggest problem in terms of Aspergillus-associated mortality. Back when we just had amphotericin B to treat, and we didn't know what our species was anyway, and it's intrinsically resistant to amphotericin, but it responds as well to the extended spectrum azoles as any others. We also be aware of the disseminated Aspergillus oostis infections have been seen in allogeneic stem cell transplant recipients despite voriconazole or caspofungin prophylaxis. So for oostis, the treatment of choice is usually a lipid formulation of amphotericin B. Okay. So I'm not doing a ton of clinical studies in this presentation, but for Aspergillus, there are a couple that we want to talk about. This is the Voriconazole versus AmphoB for primary therapy of invasive aspergillosis. It was published in the New England Journal of Medicine back in 2002. Right, there were 277 patients with invasive pulmonary aspergillosis, and they were randomized to either get voriconazole IV for at least 7 days. And honestly, these patients were mostly on IV voriconazole for the majority of their inpatient stay because the study drug was free. Right, it didn't matter what formulation it was. And they were transitioned to kind of a lower dose of voriconazole, 200 milligrams twice a day when stable, or conventional amphotericin B, and this is the dose that you have to use to treat invasive aspergillosis if you use conventional amphotericin B. That's 1 to 1.5 milligrams per kilogram per day. You guys probably can already kind of sense where this is going from a tolerability standpoint, right? The patients were on voriconazole for a median duration of 77 days, whereas the median duration of amphotericin B was 10 days. At these doses, patients just can't tolerate from a nephrotoxicity standpoint, right? So 80% of these patients had to be changed to other licensed antifungal therapy. So at 12 weeks, voriconazole was 53% successful versus 32%. That was statistically significant. More importantly, there was a survival advantage, 71% versus 58%. And this is where the idea of voriconazole being the treatment of choice for aspergillus came from. Now, obviously, you can't guarantee that these results would have been identical if you'd used a better tolerated formulation of amphotericin B, right? Anybody care to guess why they didn't compare it to a lipid formulation of amphotericin B? These were coming out. They were available at this time. Okay, so usually I get one skeptical person who's like, the drug company wanted to make sure that that their drug looked good, right? But honestly, it was because of the FDA, right? Because the lipid formulation of amphotericin B are not approved for first-line treatment of aspergillus. They're approved for patients who are intolerant to first-line treatment of aspergillus, right? So since they wanted a first-line indication, they had to compare it to a drug that had FDA approval for it, and only conventional amphotericin B did, as kind of screwed up as that is. So there was interest in a combination of an azole, anti-aspergillus azole, plus an echinocandin, because they work by two different mechanisms, right? One on the cell wall, one on the cell membrane. Maybe we get synergy. This has since been published, but they took patients with allogeneic stem cell transplant and hematologic malignancies with proven or probable aspergillus. They randomized them to get voriconazole plus or minus a nidulal fungin, and the week 6 mortality which was their primary endpoint, was 27.5% versus 19.3%, comparing monotherapy to the combo. P-value was 0.09. You can see the 95% confidence interval. So this did not meet statistical significance. Now, they did do a post hoc analyses, and they did find that those patients who were positive galactomannan from serum and or BAL, they had 27% mortality with monotherapy versus 15.7% for combination therapy. So take that with a grain of salt because it's post hoc analyses. Most of us consider this to be unfortunately, a negative finding. Doesn't completely rule out the possibility of using combination therapy in like a last-ditch effort, but unfortunately last-ditch efforts tend to come out too well. We certainly are using less combination therapy than we did before. Now, isavuconazole, which is the active drug, or isavuconazonium, which is the product that comes up from the pharmacy. They did a randomized double-blind study of voriconazole versus isavuconazole for proven or probable invasive fungal infection during Aspergillus or other filamentous fungi. And in the 516 patients in the intention to treat analysis, 258 per group, the all-cause mortality was essentially identical between isavuconazole and voriconazole. If you look at the moderate intention to treat analyses, these patients had definitive Aspergillus. Again, no difference, about a 20% mortality with either isavuconazole or voriconazole, which means we're making progress, right, compared to that older data you looked at. The overall response rate was almost identical between the two agents. There were fewer visual side effects with isavuconazole, generally a little bit less severe hepatobiliary side effects, and slightly less, perhaps, rashes with isavuconazole. Okay. Moving from, sure I took my time here. Moving from Aspergillus to Fusarium, right? This banana-shaped fungi. This is a mold found in soil, plants, and waters. It can cause superficial infections like keratitis, onychomycosis. It can be locally invasive or cause disseminated infections in severely immunocompromised patients. The more common species include Solani, in about half the cases Oxysporum, about 20 Reticuloides, and Maniliforme. This is the number one cause of toe lesions near the nail or interdigital and neutropenics. So up on 4 North at Moffitt, where we have most of our acute myalgic leukemics, if we have a patient with a swollen toe, ID goes in there right away to take a look at those patients because it could be a fusarial infection starting to sprout on us. Right? You can get a biopsy or nail removal. Right? If the nail is involved, you can pull the nail out. Partly because it's more difficult. It almost acts like a foreign body when you're trying to treat the organism. Plus, you can culture the fusarium off the nail sometimes as well. If you have disseminated lesions, you're going to need a deep biopsy. Also, blood cultures for Fusarium may be positive if you have a disseminated disease, which is something you don't see with other molds. And so here's an example of a patient, one of our leukemics, right? Thinking maybe he stubbed his toe, but you can see here that you have this erythema that's spreading up the foot. Now this patient is at risk for a progression, right? This can progress. This can get into the bone. This can require amputation. So here's a patient with multiple violaceous lesions, and usually when you have it, it's you have a multitude of these lesions, and a deep tissue biopsy, often with a little black eschar in the center there. If you do a deep tissue biopsy, and you can often find Fusarium here. This is what pulmonary fusariosis looks like. It's different than the picture with Aspergillus that we saw, and this is again because it's probably disseminated through the blood. So what you're looking at is almost a septic emboli type picture. Treatment of fusariosis, obviously, surgical debridement of localized infections whenever possible, not always possible. Amphotericin B, high dose, or lipid formulations, and really we're going to use lipid formulations because of that 80% intolerance of high dose amphotericin B. Voriconazole, Fusarium, Solani, or Reticuloides historically have been more azole resistant, whereas Oxysporum or Maniliforme are more susceptible. We saw a lot. We used to use more combination therapy, particularly in high-risk patients. We'll still do it from time to time, but we've seen a fair number of resistant fusariosis at Moffitt, and so we are now sending out. If we get a confirmed Fusarium case, we'll actually send it out to Texas for susceptibility testing, and so I tend to lean on ambisome, for example, and kind of I like to have evidence that the organism is susceptible to voriconazole before I trust it. Combination. So there's some limited data by using adjunctive GM-CSF and or interferon gamma for refractory cases as well. Okay, some emerging mold antifungal spectrum data. So Fusarium, Voriconazole, again, I like to have confirmation about the susceptibility. Amphotericin B is going to be your drug of choice typically. Posaconazole has some activity. Isavuconazonium has some activity. Less clinical experience with those. But options if your patient can't tolerate other therapies. Pseudosporum apospermum, also known as Pseudohyphae boydii. The extended spectrum azoles tend to be the drugs of choice. Pseudosporum proliferans, just pray your patient neutropenia resolves if that's the cause, because it tends to be resistant to our available antifungals. We tend to throw the whole kitchen sink at the patient and pray they get neutrophils back. That's a rare one, thankfully. And the dematiaceous molds like Alternera, Bapularis, Cubularia, Exfolia, they are relatively uncommon, but sometimes we'll see these in either prolonged neutropenic leukemic patients or allogeneic stem cell transplant patients. And these extended spectrum azoles are the drugs of choice there. Okay, I'm going to finish up with mucormycoses. These are molds from the order Mucorales, such as Absidia, Canningamella, Mucor, Rhizopus, Rhizomucor, etc. And these can cause gastrointestinal infections, rhinocerebral, maxillofacial, pulmonary infections, particularly in prolonged neutropenic patients with hemalignancies, also seen in very poorly controlled diabetics. And the mortality rate historically has been about 44% in the diabetics and about 66% in the malignancy patients. This is a Cunningamella pneumonia, right? And this is what Mucor tends to look, these ugly wedge-shaped nodules. And so here's an example. This patient was treated with, I think, ambisome and posaconazole, and they recovered their neutrophil count. And a month later, this is what the nodule looked like, right? So we were actually pretty happy with this, considering that we started with this, right? And but it can show you how long it can take to successfully treat these patients. And this, of course, these invasive fungi can come back if your patient becomes severely immunocompromised again, because we never truly eradicate it. This is the reverse halo sign. It looks a little bit like a donut, maybe a cream-filled donut. So, it's seen in this series, it was seen in 19% of their mucormycoses patients, and it seems to be fairly specific for mucor. So they saw like a single patient with invasive pulmonary aspergillosis, and you wonder if the patient may have also had mucor, because you can have both. Be aware of that too, because I've been in that situation where we actually grow aspergillus from a bronch on a patient, but the path shows a mix of septated and aseptated hyphae, right? So that patient has to be treated for both. And this picture obviously is not seen with Fusariosis, which is a completely different kind of picture. And so we're talking about showing an area of infarcted lung with greater hemorrhage in the peripheral solid ring than the center ground glass region. This is a really nasty case of a cutaneous mucormycosis in a prolonged neutropenic patient who was also had aplastic anemia and diabetes. Treatment options for mucor. So those active agents we have are amphotericin B, and at the time of this article, posaconazole. We now have isavuconazonium, right, which actually has very similar in vitro activity to posaconazole, but it's much better studied. It's better studied, I should say, than posaconazole is for mucormycoses. There's actually some studies in mice that suggest a benefit of combination therapy with amphotericin B plus echinocandin. So we would sometimes do that before we had IV formulations of isavuconazole and posaconazole as options. There was interest in chelation therapy because XJade actually has in vitro activity against mucor by binding up the free iron, which is a food source for mucor, but unfortunately the mortality rate was higher in the small, randomized, poorly balanced clinical trial. So there's not a lot of interest in that at the moment. I mentioned isavuconazonium, FDA approved for mucormycosis, which is interesting because there was not a comparator arm in this study, right? So you had the VITAL trial, phase 3 multi-center open label non-comparative trial to evaluate isavuconazonium in patients with renal impairment or IFI other than Aspergillus. They had 37 patients with mucormycosis, 32 proven, 5 probable, 35 patients on accessible end of therapy assessment, and 31.1% had clinical response. And the all-cause mortality was 38% at 6 weeks and 43% at day 84. And this is at least comparable to the historical data with amphotericin B-based therapy. And it's been compared. That data has been compared in that fashion, but this was a case where we're so desperately in need of new agents for Mucor that the FDA approved this indication, despite the fact that part of the study was not randomized. If you had Aspergillus, you were randomized to get isavuconazonium or Voriconazole. But if you had Mucor, you could just get the drug.